Assalamu alaikum wa rahmatullah. Today talk about acute liver injury management in ICU, including all categories, which can be secondary to different causes. Acute liver injury range from asymptomatic in the early stage, known as fatty liver, to severe fatal injury presenting as jaundice and elevated liver enzymes and hemolysis, which is INR more than 1.5, with change in mental status leading to multi-organ failure and coma and even death. Patients usually complain of yellowish discoloration of sclera ranging from week up to 28 weeks without pre-existing chronic liver disease. This is an acute liver injury. And change in mental status ranging from confusion, coma, or agitation and delirium. The important point to be focused in history, including the acetaminophen injection to be mentioned, the time and amount of the tablet have been taken. Also to be considered about any other drug, especially hepatotoxic drug, and also to be focused on alcohol congestion, including the duration and the amount and last time ingested. Blood and urine test should be requested, definitely including liver enzyme and serum bilirubin, viral screening for hepatitis B and C, and cytomegalovirus and herpes simplex virus and Epstein-Barr virus. Alcohol test, especially alcohol metabolites, which is ethyl glucuronide in the urine, will appear up to 4 days after last ingestion. Also, acetaminophen level should be tested in all patients with acute liver injury. Even if patient deny consumption or ingestion of any paracetamol tab, it is mandatory to be tested acetaminophen and alcohol in every patient with acute liver injury. If the acetaminophen test positive, should be repeated 4 hourly after the first test and 12 hours after the first test. And coagulation profile should be tested, including INR and factor 5 in specific, with platelet count and complete blood count. Also, arterial blood gases and arterial ammonia level should be tested if patient presenting with stage 3 or 4 encephalopathy. And this test should be repeated periodically for guidance the treatment and have prognostic value. Renal profile and electrolyte, including sodium and magnesium and potassium, should be tested. Also, blood glucose should be tested frequently in case of acute liver injury, every 2 hours. Serum phosphate investigation is also important indicator of recovery, because healthy hepatocyte consume phosphate. Also, abdominal ultrasound to see liver size and cardiac echo to exclude Budd-Chiari syndrome and other ischemic causes of acute liver injury. And if patient is stage 3 or 4 encephalopathy, it is mandatory to request non-contrast CT brain to exclude also intracerebral hemorrhage, which can also caused by acute liver injury, as well as cerebral edema. If all causes of acute liver injury are negative about investigations, autoimmune screening should be requested, including antinuclear antibodies profile. In the acetaminophen-induced acute liver injury, liver enzymes are 5 times higher than it is normal level, and ALT usually more than 1000, while in pregnancy-induced acute liver injury, which include acute fatty liver and HELP syndrome, an acronym of hemolysis, elevated liver enzyme, and low platelet. Both HELP syndrome and acute fatty liver are characterized by high liver enzyme, more than 3 times of its normal level, with high INR but usually prothrombin time are normal. Approach to the patient with acute liver injury as usual following ABCDE approach, starting with airway intubation if patient cannot protect his airway or present with massive upper GI bleeding, and better to use propofol or dexamethasone as a sedative agent for intubation. Patient breathing should be checked, and it is better also presence of any crackles or other sounds, and oxygen saturation. Most patients with acute liver injury present with hypotension. Therefore, fixing peripheral intravenous line is mandatory, and giving a fluid challenge composed of normal saline at initially, targeting MAB more than 65 mm mercury, and if not achieved, start vasopressor, which is noradrenaline. If patient present with stage 3 or 4 encephalopathy, an arterial line to be fixed is mandatory to take serial ABG and arterial ammonia level. In disability, make full central nervous system examination, and mental status of the patient should be assessed. If patient have grade 3 or 4 encephalopathy or initial serum ammonia more than 150 millimole per liter, start brain protective strategy to avoid herniation caused by high intracranial pressure or cerebral edema. So elevate head of the bed 30 degree and give hypertonic saline 3%, targeting serum sodium 145 up to 155. Mannitol is an alternative drug, but usually patient hypotensive, therefore better to be avoided. Raise the MAP from 65 up to 80 mm mercury to maintain cerebral perfusion pressure within target level, and if patient not intubated, allow spontaneous hyperventilation to the patient, or if intubated, keep and maintain partial pressure of carbon dioxide between 35 up to 45. Check blood glucose every 2 to 4 hours and maintain blood glucose level between 140 up to 180. Avoid oral lactulose because it increases bowel distension leading to bowel ischemia, but can be administered through the rectum. About management of acute liver injury, the main drug used in both case acetaminophen induced or non-acetaminophen induced acute liver failure is N-acetylcysteine. It has two different regimens. The first regimen is for non-acetaminophen induced acute liver injury, either to start by 100 mg per kg per 24 hour as intravenous infusion until normalization of INR, or to start 140 mg per kg as loading dose orally and followed by 4 hours later give 70 mg per kg given every 4 hours until 17 dose. For acetaminophen induced acute liver injury, there is one international regimen which is 150 mg per kg of N-acetylcysteine diluted in 200 ml of 5% dextrose with water, given intravenous infusion over 1 hour, followed by 12.5 mg per kg per hour infusion in 500 ml of dextrose 5% in water for intravenous infusion 4-hour duration. Then taper the dose to be 6.25 mg per kg per hour in 1000 or 1 liter of 5% dextrose in water for 16 hours IV infusion. Liver transplant is the absolute treatment of acute liver injury and indicated when patient encephalopathy and investigation result meet the modified King's College criteria. Here is King College criteria, one for acetaminophen-induced acute liver injury and the other for non-acetaminophen acute liver failure. The criteria of acetaminophen-induced acute liver injury: if patient arterial lactate more than 3.5 millimole per liter after 4 hours from resuscitation with normal saline, transfer the patient immediately for liver transplantation. Or if patient pH less than 7.3 or arterial lactate more than 3 millimole per liter after 12 hours from resuscitation with normal saline, transfer to the liver transplant immediately. Or if INR more than 6.5 or prothrombin time more than 100 seconds, serum creatinine more than 3.4 milligram per deciliter, and patient state of encephalopathy 3 or 4. These three findings, if found together, indicate immediate transfer for liver transplant center. Criteria for non-acetaminophen-induced acute liver injury, starting by INR more than 6.5 or prothrombin more than 100 seconds, indicate immediate transfer for liver transplantation. Or any three of the following findings, which include INR more than 3.5 or prothrombin time more than 50 seconds, and age less than 10 or more than 40 years, and serum bilirubin more than 17.5 milligram per deciliter, and duration of jaundice is more than 7 days, and the etiology was a drug reaction other than acetaminophen, and viral causes excluded, with autoimmune disease also have been excluded. About the external support system for the liver, this include a bioartificial hepatic support system. The bioartificial liver is an extracorporeal hepatic support system, have bioreactor containing hepatocyte to provide both biotransformation and synthetic liver function. The machine used to bridge for transplant or to allow patient liver to recover. There is 70 to 100 gram of protein hepatocyte housed within hollow fiber bioreactor. This is the main part of the extracorporeal hepatic support system. This is the machine of bioartificial liver support, including the filter containing the hepatocyte, the machine containing oxygenator and pump, and the circuit have part of a plasmapheresis device connected to it. Another type of extracorporeal hepatic support system is the molecular absorbent recirculating system. It is a recently developed form of artificial liver support that functions on a base of albumin dialysis. It facilitates the dialysis of albumin-bound and water-soluble toxins, allowing the patient to survive and even improving some clinical feature of liver failure. This is another machine from Gambro company for extracorporeal liver support, called MARS system, molecular absorbent recirculating system, used as a bridge for transplantation. Termination of the pregnancy is the absolute treatment of pregnancy-induced acute liver failure. In both cases, either HELP syndrome or acute fatty liver. The absolute treatment is delivering of the placenta, plus additional supportive treatment including magnesium sulfate infusion to prevent seizure resulting from cerebral edema, and controlling the blood pressure below 140/90. About chronic liver injury, the most common cause of cirrhosis worldwide are related to viral hepatitis and alcohol ingestion and non-alcoholic fatty liver disease. In patient medical history focus on alcohol ingestion. especially amount and last time of ingestion and duration, the total duration of alcohol consumption. Also, presence of any non-chronic liver disease and history of jaundice onset, and most complications resulting from chronic liver injury can be managed at ward or HDU level if hemodynamically compromised. Acute alcoholic hepatitis, by contrast, can occur at any time point along this spectrum and is characterized by clinical syndrome of new onset jaundice within the past 3 weeks, and coagulopathy and leukocytosis, and fever occurring in the presence of a history of recent heavy alcohol use with no other identified cause of liver injury. Through history for heavy and chronic alcohol use should be taken, as alcoholic hepatitis can occur even weeks after the patient has been stopped drinking. So alcoholic hepatitis is an acute inflammation of the liver characterized by AST over ALT ratio greater than 1.5 or greater than 2, has been highly suggestive of alcoholic hepatitis. Management of severe alcoholic hepatitis is corticosteroid, and this is indicated if patient with severe alcoholic liver injury with MADRE discrimination function score more than 32 or model for end-stage liver disease score MELD more than 20. Oral prednisolone 40 mg per day is recommended dose. For patients unable to receive orally, intravenous methylprednisolone 32 mg per day is recommended. This is the MADRS discriminant function score. It is equation that contain constant 4.6 multiplied by prothrombin time in second minus control prothrombin time, which means the time increased in prothrombin plus serum bilirubin by milligram per deciliter. The total more than 32 implies severe liver disease with poor prognosis and indicate initiation of steroid treatment in alcoholic liver injury. This is the second score, which is a model for end-stage liver disease used for initiation of corticosteroid treatment in alcoholic liver disease, especially acute alcoholic hepatitis. Alcoholic withdrawal symptom is another form or result of chronic liver injury. It is acute, occurs after alcohol abstinence by 3 to 8 days. Patient mental status usually agitated due to withdrawal symptom of alcoholic induced liver injury, and the treatment give oral or intramuscular benzodiazepine. This is the first line treatment. Second line is dexmedetomidine. Dexmedetomidine should be avoided in heart block patient. Also, propofol can be safely used as an alternative medication. Intravenous thiamine should be replaced prior to initiation of glucose-containing intravenous infusion to avoid precipitating of wrinkles encephalopathy. Upper GIT bleeding is considered one of the serious complications of chronic liver disease and acute on chronic liver injury. Varices is responsible of 70% of upper GI bleeding with hemodynamically instability in acute liver injury patient. Early endoscopy within maximum 12 hours from presenting symptom should be done. And if variceal bleeding confirmed by endoscopy, intravenous octreotide bolus dose of 50 mg followed by 50 mg per hour infusion rate is recommended, with infusion continuous for 3 to 5 days. If bleeding continues after endoscopic therapy, balloon tamponade using single-station Blackmore tube, which should only be inserted in intubated and sedated patient up to 24 hours. Portable abdominal X-ray should be performed prior to balloon inflation to confirm position of the balloon. and avoid non-selective beta blocker in acute upper GI bleeding. If patient develop stage 3 or 4 hemorrhagic shock secondary to upper GI bleeding, start massive transfusion protocol immediately by ratio of 1 platelet, 1 fresh frozen plasma, and 1 back cell RBC. Correction of coagulopathy if any invasive procedure required. Acute liver injury is frequently associated with thrombocytopenia and elevated INR and low factor 5, less than 50%, and disseminated intravascular coagulation. All categories, either drug-induced or non-paracetamol induced or paracetamol induced, or acute on chronic liver injury. All the categories of acute liver injury should be received parenteral vitamin K 10 milligram single dose for 3 days. And also, before any invasive procedure done, recombinant factor 7, activated factor 7 should be given at dose of 80 mic per kg intravenously bolus over 3 to 5 minutes. It provided up to 4 hours of coagulation correction for placement of ICP, for example, intracranial pressure monitor, or central line or arterial line. Fresh frozen plasma and platelet and cryoprecipitate are alternative medication prior to invasive procedure. Renal insufficiency can occur as a result of acute liver injury, and most of the cases either due to pre-renal or acute tubular necrosis, but some may develop hepatorenal physiology as well. Aminoglycoside and non-steroid anti-inflammatory drugs and other nephrotoxic drugs should be avoided. Continuous veno-venous hemofiltration is preferred over hemodialysis due to less frequent hemodynamic instability and improved outcome in acute liver injury patients. It indicated when metabolic acidosis with pH less than 7.0, stage 3 acute kidney injury, and serum arterial ammonia more than 150 micromole per liter. Other complications like hepatorenal syndrome and spontaneous bacterial peritonitis can be managed at ward level.